Assalamu alaikum, respected chairperson, moderator, panelist and all participants. I'm going to present a CD about Antegrade LED CTO PCI after opening of RCA CTO where there was no visible septal collateral connections. Our patient was a 61-year-old gentleman presented with history of crescendo angina over couple of months. He was smoker and hypertensive. He had history of several times hospitalization but never evaluated invasively. His LV ejection fraction was 45%. Baseline angiography shows LED CTO at the proximal part with retrograde filling from the conal branch of RCA. There was another CTO at the mid part of RCA, retrograde filling of distal part from the left side. Ramus intermedius was good sized, having 90% stenosis at its proximal part. LO caudal view shows LED totally occluded at the proximal part, no ipsilateral filling. Ramus intermedius has 90% stenosis at its proximal part. RCA was early divided and the major branch is totally occluded at the mid part, conal branch filling LED. LO cranial view shows occluded RCA branches retrogradely filled from the LCX. Patient was advised immediately for CABG but he denied. Then he was put on maximum medical therapy and detailed discussion was made about the possibility and outcome of the PCI with the patient and his relatives, but patient decided to undergo PCI. There was some complexity about LED CTO as its length was 20 mm, side branch at the proximal cap, distal cap was convex, there was some calcification and there was no appropriate interventional collateral. So according to hybrid algorithm, Antegrade OIR escalation strategy was taken and PCI was started with RCA. With the help of microcatheter and pilot 50 OIR was crossed the occlusion. Balloon dilatation was done with 1.25 mm and then 2.5 mm. A drug-eluting state of 3x40 was deployed in the RCA with good TB3 distal flow. Then LED CTO to ensure better collateral visualization of post-CTO portion of LED, a microcatheter was parked in the conal branch and Antegrade OIR escalation started. Using OIR Conquest Pro 12, managed to get through the occlusion in the LED. Distal cap was punctured and was confirmed by retrograde injection. Then OIR exchange for round-through OIR was done. Then gradual balloon dilatation was done to LED. After balloon dilatation of ramus intermedius, a drug-eluting stent of 3x40 was deployed in LED. Post-dilatation with 3.5 NC balloon. OIR exchange to ramus intermedius, another drug-eluting stent of 2.5x18 was deployed in ramus intermedius. Then tap and kissing balloon inflation was done to ensure optimal stenting. Post-dilatation of LED was done and this is the final result. Whole procedure took 220 ml contrast volume with fluoroscopic time 58 minutes and radiation dose was 3.6 gray unit. Antegrade OIR escalation is the best strategy for CTO opening in most of the cases. Collateral connections from opposite side, if seen by contralateral injection, the job becomes easier. When no collaterals apparently available, then search for other sources. Above all, it is the proper planning that brings success to such a critical, such a complex interventional case. I am grateful to Dr. Habibur Rahman, Associate Professor and Senior Consultant, Department of Cardiology, for giving me the opportunity to present this case. Thank you.